Health Gap and fellow at the Center for Public Health Initiatives at the University of Pennsylvania.
So I'm going to try to talk through really briefly some of this kind of question of should we do more with less and the fallacies therein, but there are some community-based ways in which that can happen that is not doing less with less, although I guess I'm here in part to sound a little bit of a danger alarm. So here are three things that I have heard incessantly, less in this room, which I appreciate, but I heard the first day out of a certain leader's mouth, right? Efficiency, country ownership, and more with less. I think all three of these are incredibly dangerous depending on how you interpret them. So I'm going to try to talk through what are some pro-patient efficiencies, and then what are some negative, patient negative, and also task negative pieces. So many of you will be really familiar with some of the models that have been put out there, including the KIP, the CBART study, looking that actually found better suppression when you devolved to community, right? And being able to do that, being able to get the same mortality rates as a hospital-based setting, but it should be noted, costs come down, but it's still 10 to 35 times the local budget. And so as we think about what a community-based model looks like, it's important to say it's not going to cost nothing, right? And if it does cost nothing, then we're not actually getting good programming. There's another great model that we really like, the MSF Malawi pieces in a variety of districts. I misspelled that. So they decentralized to get within 10 kilometers of the patient and used ART support groups and community health workers for adherence checks, and they got 98% remaining in care, which few programs kind of across the world are getting, and that's it's pretty impressive. So one option in terms of, just to say one option in terms of what a pro-patient efficiency looks like is getting it closer to patients and figuring out how that creates efficiency in the world. Second pro-patient efficiency I would throw out there is the use of community-based assets, right? So we think about networks of people living with HIV, we think about community health workers, we think about all of those. If we think about them as assets in real ways, it doesn't mean we can't pay them or don't need to pay them, but it does mean that there are ways to use them. So the Mozambique example of the community ART groups, which I think are fantastic, right? Elected leaders, monthly rotation of ART collection, once every 6 months. Community health workers are critical in it. Their participation was based on, as folks had said previously, stable patients, but they had a 97% retention in care rate, a 0.1% loss to follow-up. Raise your hand if you run a program that's got that, and you win too. So thinking about ways in which people living with HIV are actually able to themselves access care and support that, even in the lowest of income areas. Patient efficiency number 3, better drugs, right? So the switch to tenofovir is critical. It's disturbing how many programs are still running with tenofovir, including some people that are still initiating with tenofovir, which is terrifying to us. That process of moving to tenofovir is, with D4T. I think tenofovir is what we need. D4T is the thing I'm worried about. This is what happens when you speed through slides, right? The piece of getting better uptake, all of the things that we all know are much better with tenofovir, but I want to put out there this question of then what, right? Because as I'll talk about in a minute, we often don't have a second, and we certainly don't have a third line often. New drugs as they come online, dolutegravir, the prodrug, the question of how are we actually going to get them, I've got you up there, right? Chai is obviously doing an incredible amount of work here, but I think we need to recognize kind of 3 things. One is these drugs are going to be patented in India. And so this is going to be a problem, right? And so the model that we've had is not going to work. And so we need to figure out how to address that. We need to figure out how to capacitate countries to actually make use of the intellectual property flexibilities they've got. For those of you that want to be researchers without intellectual property attention, please pay attention for a moment, because all of these models crash and burn in a couple years when we don't actually have a second line as we move forward. Voluntary licenses that are getting put out there right now are often excluding the middle-income countries that Catherine was mentioning is where people living with HIV are going to live. And so given that reality, the lack of attention to middle-income pricing is a huge problem. And right now, just for what it's worth, the WTO is considering extending the LDC extension, and that's a huge area that we might kind of pay attention to if we're looking for pro-patient efficiencies. Viral load needs to be rolled out in various places. I think somebody was saying we get this is my cascade, right? This person who's also been up on the on stage many times. It's essential, but it's also cost saving in the long run. And if we're thinking about TASP for real, we have to be thinking about viral load, thinking about point of care viral load, and making that possible. Final point on patient efficiencies, human rights, we think of them as something that's a nice buzzword. Ruben and others did a really nice study costing what they cost, right? And so thinking about how do we build that into programs and saying, can we put 1.5% of the total money into a human rights program? Because in the long run, I would argue it's going to be cost saving, right? But in the short term, it actually costs money. If we don't invest now, we're in trouble. So are we making progress? Are we there? So percent of public sector facilities with ART, one key thing that affects people's access, a lot of variation across countries about how much access there is, everywhere from Nigeria all the way up to Kenya. Great. No nurse initiation in many countries. No third-line protocol exists in all those countries, and community-based ART is in the guidelines almost nowhere. So what are the anti-TASP efficiencies? Deciding not to expand. Right now, there's a huge issue with, is there money to actually put into DRC? The use of older drugs, you can see there the percentages of folks that are still using D4T, which are unacceptably high. Non-adoption of guidelines, right? Still, South Africa just switched over. Zimbabwe just barely is moving toward maybe adopting the guidelines, and it's all about money. Finally, cuts to programs. Right now in Uganda, we're seeing the B+ rollout jeopardized because we don't have the support that's necessary to actually make sure that the follow-up happens. This is the first thing we see when there's, we're gonna make efficiencies. And right now there's a shortage of testing kits in Kenya. This is the kind of efficiency that when we put pressure on downward, we're gonna see. Finally, I just want to show 3 quick things, right? Charles already showed this lovely slide, which is my favorite slide ever to talk to decision makers with. Pay now, pay later. But look, it does actually cost some money. Here's another slide that Bernard Schwartlander shared at the Global Fund replenishment meeting. We need to get some, in terms of getting number of people on ART, I think it's worth noting that this number over here and this number over here are actually the same. Right? And so the question is, do we put people on ART now, or do we have an ever upward trajectory? $27 billion or so is about what we need. Somebody asked that earlier. And so we're somewhere $10 billion short, which sounds like a lot of money, but is not so scary. Also, somebody mentioned earlier, where's the modeling for no CD4 count, right? Let's think about that and put that into our models. Final slide. Long-term decisions based on short-term funding. This is my current worry, right? And so I've heard things like, shouldn't countries that have low coverage right now wait to implement the guidelines? Shouldn't we think about drugs, continuing the life of drugs that are actually really lousy for patients? All those kinds of efficiencies, which we just should know in this room, are what many people are being pushed toward, right? All of those are gonna undermine TASP and cost us more in the long run. Final point is just, all of you researchers, we need you to be a little bit more of activists sometimes, because if you don't help us win this money, right, then TASP is a lovely concept that's not gonna be possible. And I think Charles made the point earlier that programs are hitting their threshold levels, right? We're seeing saturation. It is very real. 3 years ago, we were seeing waiting lists. We're gonna see them again a year from now if we aren't smart and strategic about how we move on some of these things. Thank you.